let's get away and change just a little bit, because one thing that this is one reason I'm so excited about this particular sort of an image-based or image-guided biopsy technique. There's so much out there about the complications of biopsy, and where we're seeing a significant elevation of fluoroquinolone-resistant E. coli in this country and multiple countries. There have been multiple papers out there. There, the bleeding risk, obviously, but infection has been one of the primary concerns. How do you cover your patients there at NYU? Do you have a particular algorithm that you follow, and do you have particular patient populations you cover differently because they're at higher risk of infections?
Yeah, it has been a growing problem, and we've observed at NYU that if we look at patients coming into our emergency room with community-acquired pneumonia, about 25% of them have quinolone-resistant organisms. So the quinolones are really becoming of less and less value to us as urologists in prophylaxis for our procedures and invasive types of surgical interventions. And so for that reason, we've tried to address it by altering our overall antibiotic regimen. Now, if you look in the literature, it's pretty much consistent that people are noting a growing rate of post-biopsy sepsis from what used to be less than 1% to in recent years as high as 3 to 4% in some cohorts. People at high risk, as you mentioned, would be healthcare workers who are exposed to resistant organisms, people who've come from international travel, people who've had multiple healthcare procedures. So if a patient tells you, I just got out of the hospital from a cardiac bypass, or I had complications from a colectomy and I was in the hospital on antibiotics for several weeks within the last year or 2 years, that probably has left them with resistant organisms. And so one has to get a little better history before the biopsy to understand an individual's infectious risk. And there are really two approaches one could take. One would be something that we've talked about at the AUA, which is to individualize antibiotic therapy. The way you do that is to take a swab from the rectum, streak it on I think it's a chocolate agar plate, and let it grow and see if there are resistant organisms there. In my experience, that requires a lot of communication with your lab, because obviously a rectal swab grows a lot of organisms out. It's typically a polymicrobial swab, and the lab is going to say, what do you want us to do with this? So you really need to have a prospective strategy with your institution or your local lab if you're going to do that. The other problem with that approach is it's a tremendous burden on your workflow in many offices. Who's going to do it? When's the patient going to come in? Do you have room in your waiting room for all these people coming in a week ahead to get a culture? The other approach might be to consult your local infectious disease doctors and ask for what's called an antibiogram. Typically, an antibiogram is a survey of infections that have occurred within the community or within that healthcare system. And it reflects how often we see resistant organisms and what those resistant organisms might be sensitive to. We did that at our Manhattan VA. In previous years, I've served as the chief at the Manhattan VA, and we noted an increasing rate of post-biopsy sepsis in our veteran patients undergoing prostate biopsy. And what we saw was that over a 3-year period, our rate of sepsis increased from roughly 1% to about 4%. We had some near-death sepsis events. So looking at the local antibiogram, we did away with quinolones and converted our prophylaxis to a single dose of gentamicin and a single dose of ceftriaxone at the time of the biopsy. In the 3 years that followed that, roughly 450 men, our readmission rate to men receiving that regimen was 0 for sepsis. So we dropped it from 4% to 0 over the ensuing years. In our private offices, we continue to utilize quinolones, but use them in combination with ceftriaxone as a single injection based on the antibiogram at our private center. So I think that's an effective strategy with a lower workload. Now, many would argue that over time you'll just draw out resistance to those antibiotics, and that suggests that it has to be a dynamic process in which you're revisiting the local antibiogram every year or 2 years to readjust your prophylaxis regimen and use as minimal a regimen as possible.
I've heard people from the UK discuss the increasing use of transperineal biopsies because of concerns of just what you said. All we're doing is chasing the bugs, and the bugs are smarter than we are, and they're evolving faster than we are. And that concern has led them to say, let's stay out of the rectum and go back to transperineal. When I was starting in residency, that's what we did, and it was very painful for the patient. Do you see us ever, you've mentioned transperineal biopsy, do you see us maybe changing techniques to try to avoid some of these infectious complications?
Well, I think if you use a transperineal biopsy, it certainly will lower your infection rate because skin colonization doesn't seem to influence greatly the risk of prostate biopsy infection after sampling. The problem is twofold. One is what you mentioned, that the workflow and the patient comfort, these things are major practical issues. Where would people do these biopsies? Thinking about how many biopsies we do in this country right now, at least 1 million a year, and how many biopsies the average urologist does in his or her office, it's really difficult for me to believe they would find a comfortable workflow where they could take patients, sedate them, or put them in a proper OR suite or wherever they want to do it to do a transperineal biopsy. I think the other thing that worries me is I'm not sure transperineal biopsy is as good a method for sampling the peripheral zone as transrectal biopsy. I don't think the imaging suggests to us that we get to the same regions of the prostate. So how that would influence primary prostate cancer detection, I'll be interested to see as some of these series evolve.